Thank you, Mr. Chairman. I want to thank Dr. Stone for being here and giving us this important update, incredibly important. So I appreciate having this opportunity. I wanted to point out, Dr. Stone, that my staff talked to the Southern Nevada healthcare system this week and heard that many of the employees that they spoke with personally felt that the support and outreach from VHA and VA from the beginning and throughout this pandemic has been the best they've ever seen in their careers with the VA. So I was clearly delighted to hear that and hear that you've been seeking best practices from the field and working to share all that with all the facilities. Dr. Moe, I'd like to move on and talk a little bit about the VA's methodology in counting positive COVID-19 patients. The VA clearly distinguishes between VA employees and veterans. However, many VA employees are actually veterans themselves. So my question is if a VA employee is a veteran, are you counting them in both categories? And if not, have you provided guidance as to which category they do fall in?
Yeah, our guidance that's available is that they are counted as a veteran. So if they're a veteran and an employee, they're counted as a veteran.
Great. Dr. Stone, in April 2020, April this year, the VA began using this national surveillance tool to track the cases of COVID-19 across the country. And I understand that this has obviously improved the data that the VA has been reporting. I also understand that in the month of April, there were at least 2 substantial downtimes that caused the tool to be unavailable for about 8 days. During that time, was the VA able to continue to track data related to the COVID-19 infection rates and deaths during that time?
During that time, we were able to track part of that whole portfolio of information. We were limited because of some systems issues and some other technical issues to put that full report out.
So let me add to what Larry has said here, Congresswoman. We are operating very advanced data modeling, and look, there's 50 different models of COVID around the world. We really like ours, but when those systems go down, you need a redundancy. And one of the things we have is a very robust health operations center that literally twice a day brings together various leaders across the system. We were able to obtain the data we needed to manage from during the time that our primary system was down by those learning events where literally 1,000 leaders in the system come on at 3:30 every afternoon Eastern time and spend an hour back briefing us on the status of their equipment, status of their hospitalizations, status of their personnels, the number of personnel under investigation for COVID, as well as their positives. So the redundancy in the system helped us through this. But make no mistake, we want that system to be reliable, so we are not encumbering our leaders to give us manual data draws any more than I find it acceptable to do manual data draws in our supply chain system.
So it's safe to say that there was no sacrifice in terms of the quality of the surveillance data as a result because of the redundancies?
That is correct.
Great, that's great. Were you able to identify the root cause of what caused this downtime? And if so, what are you doing to prevent future recurrences?
That is an IT question, and I have not gotten the briefing on why we had found that downtime, but that is one of the things on my list. This is my 3rd testimony in 8 days. I need tomorrow to go into some depth of getting some back briefs on some of these issues that I haven't been able to tackle. I'm sure that there are other people in the organization that know why. I'd like to hear it.
Great, that'd be great. If you could follow up with me, I'd appreciate that. And thank you again for spending the time with us today. Appreciate it. I yield.
Thank you, Ms. Lee. I now